Hello, everybody. Thank you for tuning in at DDC study group today. My name is Sander Polanco. The DDC study group provides educational events in the form of group discussions, lecture presentations, podcasts, and products and technical demonstrations on topics in dentistry today. Today we have a lecture presentation with topic on all-on-4 conversions technique, overview for immediate low, brought to you by technician Dora Rodrigues and a good friend of mine. We just want to thank our sponsor, Top Products and ShareSide Lab Solutions. This presentation is interactive, so feel free to ask questions, and I will be moderating and looking out for them. Now let's get right into it with Dora. Thank you, Dora, for doing this at this time.
And thank you for having me.
Yes. So you can introduce yourself and let's start the presentation.
Okay. Hi, everyone. I'm Dora Rodrigues. I opened my dental laboratory in 2016, so just 3.5 years ago. Before that, I worked at Malo Clinic. And for those that are into the all-on-4 business, you'll most likely know that it was founded by Dr. Paulo Malo. And he was the developer of the all-on-4 treatment concept back in the day. I'm original from Portugal. I started working at the Malo Clinic in Lisbon back in 2004, right after I graduated. And then 2 years later, I moved here to the United States. And I worked there for another 10 years. We moved to set up their international lab. And then I stayed managing their removable department until 2016. I decided to go on my own. I'm not a full service lab. I only work with full arch restorations, here more specifically with the all-on-4 conversions, the topic that I'm gonna present today. I started working with digital dentures about 1.5 years ago. Before that, I was strictly analog. And the reason that it took me so long, honestly, is because at the time when I opened my lab, I didn't see the need to dive into the digital world. It was just me. I was not that busy. I was able to do everything in-house. My lab was fully ready to do the analog workflow. So at the time when I first started, I didn't see the need to get into the digital. But by the time passed, I started getting busier and realized that in order to keep up with the demand, I had to or hire someone or go digital. So the reason that I chose digital mainly is because I'm still able to control the planning and I can outsource the processing part. I use Avident for most of my mill dentures now. It works great because I didn't have to make a huge investment when I got started. And I can outsource the planning and still I can control I can outsource the processing and still I can control the planning stage. So, I still take fully control of that. And because, Avident provides some monolithic dentures, then I know that they are good for the purpose of the conversion. I'm not sure what kind of audience we're going to have. So keep in mind that this workflow I'm going to share is what fits my business model. And this business model is very particular. So I'm a one-person lab. I have different offices in different locations that I work with. And after planning the cases, the surgery schedule, and I go to the offices to help with the conversions. So Sander, feel free to, if there's any questions, feel free to interrupt because I feel that it's easier to answer the questions halfway than just waiting till the end. So let me
Sure, I will be looking out for them and I will let you know.
Let me share the screen. How do I share my screen? Now that. Is it here? Is it good? Did I do it right? Hello?
Yes. Yes, go ahead.
Is it good? Is it centered?
Yes.
Okay. So All right, let's talk about conversions. A conversion is basically the act of converting a pre-planned denture into a fixed screw retained restoration. And that normally is done right after the implants are placed. Keep in mind, again, that there are different protocols out there, and this is just one of them. This is the basic of the basics, let's say. So if you are an in-house lab, your protocol might be slightly different. If you have access to digital technology like intraoral scans or the PET camera or something like that, then your protocol is definitely different. So this is what works for me, what I've been doing, and how I was able to find a protocol that I can work with different offices around my area. So, all right. All-on-4, ProArch, All-on-X, different companies give them different names, but honestly, they're all the same. And basically, it's just the rehabilitation of the dentalist patient or patients with terminal dentition with 4 or more implants and a screw retain fixed bridge. The norm is 2 straight implants in the anterior, 2 tilted posterior implants. But that honestly, it all depends on the implant planning and the condition of the bone. And sometimes you'll plan for 4 and you end up using 5 or 6. So that really depends. That's not, we don't use just, all-on-4s. We can go up to 4, 5, 6 or more. All right, so I tend to divide these in 3 different categories. So the first will be the preliminary records for the denture fabrication. Then we will have the in-office conversion that is done. It happens the day of the surgery. And then we have the final impressions, the final restorations that are, we're not going to go over that topic. That is a completely different presentation. So we're going to stick to just the 2 first ones. So preliminary records or pre-op records is the same. We will get them for any other case. And basically we'll need upper and lower impressions and a bite. They can be regular impressions like PVS or alternate, or nowadays a lot more intraoral scans are coming our way. I definitely prefer intraoral scans over the regular impressions, just because this type of situations are very frequent and a lot easier to register with an intraoral scanner. I mean, I wouldn't say easier because I'm sure it's difficult for the doctor to scan this, but it's a lot more accurate for us for me to plan the case if I have an intraoral scan, because we need proper records for a proper planning. And it's very difficult, or I must say almost impossible, to get a good denture out of this kind of records. So let's dive into the denture planning fabrication. So let's talk about options on fabrication. We can have analog dentures and we can have digital dentures. I'm not here to tell you that one is better than the other. They both work. What I have to say is that, we have to understand that digital technology is here and is evolving pretty quickly and is giving us tools that analog doesn't have. So the biggest tool that we have with digital dentures is definitely the data, being able to save it or being able to add or remove, change it, and delete and then bring it back again. With data, if you work with digital technology, nothing is lost. You'll have it forever. And one of the switches, the turning point for me to dive into digital dentures was also when I had this unfortunate situation where we did an all-on-4 and we converted the denture. 2 of the implants failed 2 or 3 months later, and the patient had to go back to a denture. And at the time, because I was working analog, I didn't have any records of it. So we had to start the case all over. We had to go through new impressions, new articulations, rushing a denture overnight because the patient needed a denture the next day. So you might say, yeah, it's not a big deal. You can do a denture in one day. Yes, you do. But for me, working, alone and having back-to-back surgeries and a tight schedule, it was not the best at the time. So This is why I started looking at digital different, because of the data. If I had the data saved, it would be easier to, to just print or build a denture and send it out the next day. All right, inside the digital dentures, we still have printed and milled dentures. We all know that printed resins are a little bit more brittle, and they have a higher chance of breaking if you compare with milled. But I have quite a few in the mouth, and they work fine. As long as restorative space and proper protocol is followed, they do not break. So if you're having problems, probably it's not just the materials, it might be something else. I still prefer mill dentures. So like I said, I use Avident for most of my cases now. They're out of Arizona, and it's pretty easy for me. I just need to scan the models, send these instructions. They give me a preview. I can either approve, do the changes myself, or send, ask them what changes I want them to get done, just in case I'm busy, if I'm in a surgery, if I on vacations. And then, once the design is back, I approve, and they process the denture for me. So I don't have to worry with the processing. So that was a big thing for me as well, because again, when I start getting busier, I couldn't manage my time properly. So it was a lot easier to just outsource that portion of the work. And again, because it's monolithic, I know that the strength is there for this type of cases. For the conversions that we're going to look a little bit further, we need to make holes on the denture in order to pick up on the cylinders, and we're weakening the denture, so we want to make sure that we're using a good material. So the reason that I would choose or the reason that I still do printer dentures, or the reason that I do one or the other, is basically when I don't have enough time for the processing stage. So I have some offices that, sometimes they give me a week for, a surgery. The patient is in a rush. We all know those patients, or they have a wedding, or they're going on vacations, or they want this kind of procedure, they want it next week. And I found that doing printed is easy for me. If I'm too busy, outsource source the design while I'm working something else. I still control design, because again, I have the data there. I can, cross-reference with what the pre-ops and the new designs, and easily for me to get the STL and print in-house, assemble, and we're ready to go. So let's talk about planning. I'm going to give different options. So I work with, pretty much all of them. This is, like I said, I don't do many analog cases anymore. I'll still do some if I have, I still have inventory for teeth, so I need to get rid of those. But if I have the time, so probably after this coronavirus situation, probably, I don't know, maybe I'll have time to to use those extra cards that I have. But analog, if you're strictly analog, no big deal. You get your impressions, you pour your models, you get your articulation in place, analyze it, and then we need pictures. We need pictures for any type of work, but this is extremely important because we need to plan the case correctly. So these are the pictures for this case. This is one of my very first ones. I don't have much of the, of the entire planning, but I request 3 main shots for this type of cases. There will be regular smile, high smile, and profile. And preferable, they should be center, eyes open, no sunglasses. I had those coming. And you need those in order to relate to the models. How do you relate them to the models? We got the pictures, we cross-reference, and we start planning the tooth position. We're not gonna dive into the planning because we're just overviewing the entire process. And if I start diving into that, it will take another 3 hours. And I'm showing just different options and how the planes relate, either analog or digital. So just keep in mind that although we're processing this as a denture, this is not a regular denture. We have to look not only at the basic landmarks, just like the midline or the smile line, but also vertical dimension, muscles of the face, restorative space, possible bone reduction. If we need to reduce bone, how much can we reduce? If can we play with the vertical dimension? If we do that, are we going to affect the patient's function or the condyles? We have to take that all in perspective. So there's a lot more to consider in this type of plans, because like I said, I normally say I don't do dentures. I do dentures for conversion, and to a point that has to be differentiated because it's completely different. The type of planning is completely different. I don't have many records after this, but we got the dentures ready after the planning, and this is the result for that patient. Moving, let's say we went over planning. This is an upper and lower. Dentures are ready. What else do we need for surgery? I'm going to use this case later on to show the part of the conversion process. So we have the dentures, and we're getting ready for surgery. We need what's called a stent. And the reason that we need this, or at least I need this, is because most of my doctors are freehand. So they still use an implant software for the planning of the implants, but they do not use a surgical guide or a pilot guide. So they still plan the case. They know where the bone is. They know where the implants go, but they freehand the surgery. So for that, and for them to know what to follow or what type of restorative space I need for my conversion, we do this what's called a surgical stent. That is basically okay. Do we have questions?
Yes, Dora, how are you?
Okay.
So I have a question from Dr. Jeffrey Hoos. Do you ever ask for a Gothic art tracer for your records?
Sometimes it really depends on how the bite is.
Okay. All right, you can continue.
Okay, so in order to get oh, hold on, is this on the way? No. So in order to provide the stent, so the stent is basically a duplicate of the denture, and easily done in the analog. Nowadays I do it digitally, and I'll show in a little bit further how you can do that as well. But you have to take into consideration that you need 15 millimeters of space, of restorative space, for this type of cases. So if you're doing a hybrid, we're looking at 15 millimeters. If you are looking at final restoration like zirconia, you can get away with 12, 13. So sometimes I don't know what kind of final restoration the patient wants. So I always follow the 15 millimeters guideline. So I'll have those marks on the buccals, so the surgeon at the day of the surgery, he can use that as a guide for the proper bone reduction, so we are sure that we have enough space for the final restoration. And then we also do a lingual opening on the lingual of that duplicate denture, and that will help us to position the angulated abutments for the after the implants are placed. So this is an upper and lower. So the lower is the same thing, the same guidelines follow. We do the marks on the buccal side and on the lingual, and we are ready to go for surgery. So as you can see, they're interchangeable. So it's basically a duplicate of the denture. So yeah, this case will be showed for the conversion process, but I want to go over other ways of doing things. So if we dive into the digital route, like I mentioned, Avadin is my first choice for mill dentures. I'm a control freak, so I like to control the planning. And with Avadin, like I said, I can also outsource the manufacture of the denture completely. It's a lot more cost effective for me. If I had to buy a mill to do it in-house, I still needed to worry with the finishing. And, I already do that with printed dentures, so I prefer to avoid that. And the way that how it works is they have the Evident Connect is the cloud, and basically you just create an account. Everything's done in the cloud. You don't need a software. You don't need a specific computer. You just send the scans, instructions. They do the setup, and then you either approve it, you do the changes yourself, or you tell them what changes you want to do, and then they go ahead and they process it all. So that works for me because I'm getting to the point that I'm so busy that I can just outsource the processing is a lot faster, and my time management is a lot better. So the software that they use is slightly different from what we use from 3Shape and Exocad, but it's a little bit of a learning curve, but it works fine as soon as you learn it. And if you're looking to dive into the digital world, I think that this will be the best way to go if you don't want to invest in softwares or equipment at the beginning. And these are the the results. There are monolithic dentures, so even in those thin areas over there, these are more than tested, so I wouldn't worry with that area being so thin for my conversion. If I was doing this case in analog, maybe I would increase the acrylic in that area a little bit, but with these cases I'm not worried. All right, another option, 3Shape. If you have the software, great, you can do it yourself. If you're too busy, again, you can outsource it and have someone designing for you. There's great designers out there. I work, we're in the DDC group. You've seen for, the past week that they have a lot of great designers that they do it all. So again, this is what works for me. If I'm too busy, if I don't have enough time to get my cases done, I'll outsource the design. This is a case that the doctor wanted in a rush, so I actually had Sander working on this one, and it works fine. I have a printer. I can just get the files, print them, and we're ready to go. So these are the pictures of that case. This is going to be an upper and lower, and the doctor sent STL scans. And in this case, you can see the second picture over there. He couldn't scan the palate. The patient was a gagger. She would not take any more impressions, even with the intraoral scan. So it's just do what you can and make it work, basically. So we use digital smile design. We cross the models. We analyze. We refer to the pictures. We analyze. We go over the planning. Basically, we analyze the face, tooth position, vertical dimension. Confirm restorative space, what kind of how much bone reduction we need to do, and then this is the design that we come up with. And if you see that area over there that is very thin, so we kind of pushed a little bit. That was because the scan couldn't, the scan was not the greatest, so we pushed a little bit more of that flange over there. And this was my very first case digitally, so I just printed one piece. I didn't know what to expect, so I printed one piece, and then I just add a little bit of resin on the facial, just to cover that the white of the denture resin. But I still have to bring resin to the office, because once we cut the flanges and we convert the case, there's always some adjustment, so I always have extra resin in hands in the office if I have to. So after that, we got the stents as well. Again, like I said, most of my doctors are freehand, so we need the stents in order to correctly place the abutments, and for a guide for the bone reduction. If you see in this case, there's no marks for bone reduction, just because it's very, this is pretty much the bone reduction, so he will just use that, the end of the flange as a guide. So for the printed stents, I do it in Mesh Mixer, and I have to thank Jeremy Winderger. He's brilliant in Mesh Mixer, and he teach me how to do this. is literally less than 5 minutes, and I will play the video. But before that, I have to say that, because I'm not brilliant with Mesh Mixer, I just know what I need to know for what I need to know for my work. I'm in the process of learning, but I needed this right away. So I use the shortcuts. It's a lot easier than trying to, for those that don't know, trying to figure out, how to go to select, and then a new window pops up, and then a new window is very time consuming. So I use the shortcuts. So basically, you'll use the S for select. You select the area, both sides, and then you X it out, so that discard their area. And the main thing here is you have to go to allow back faces. This is what gonna allow you to select that area on the other side of the denture and then discard that as well. So that is basically what you have to go in order to do this properly. You won't be able to select just one area. You won't be able to select both areas without selecting that allow back to faces. So basically, you ask for select, you cross it out, you X to discard, select back faces. I reduced the size of the brush a little bit so I can see, I didn't go crazy over there. And then once you have allow cut back, the cut back faces, you hit select, control bridge, you're bridging, making like small holes, or you're making small holes on that big hole in there. And then you just need to run inspector, and the program itself will cover, will close all the other little holes in there. So this is a little bit fast forward, but literally this took me less than 3 minutes to do. Then you just need to go get your brush and smooth the area, and then you're good to go. And then of course you just need to go to export, and you have your stent ready to print. Okay, and this is the result after the conversion. You can see it's a great before and after, although not happy how the midline is slightly off. But at this point, if you remember the scans, we didn't have a palette, so it was really hard to kind of sit it in the right place, because once we flap the tissue, it's really hard to adjust, the denture properly without having the palette as a guide. That came out pretty well. Patient was happy. So this is another option. This was done with Exocad, another rushed case. I sent this out this was with Daniel Portal. He's also in the group. We did a couple of cases together as well. We discussed instructions. We analyzed vertical dimension, choose position, and so on. And I got back this design. You can't really tell from the picture, but we also closed the vertical dimension in there. So I already know that when I'm going to print this file, or when I'm going to do the conversion, the tooth display is not going to be as much as what we see in that picture. So in this case, the very first case, I printed one. Complete piece. In this case, we decided to try a new thing. We did a cutback in the interior, so we could have some composite or resin to make it work a little bit better. And in this case, I used composite because we needed to characterize the gums for that type of patient, and we use some dark colors. And that was the result after the surgery. So you can see the exposure of the teeth from, the planning is not, you have to understand that what you see on a picture on the design, because it's a picture, it's not, there's no motion there, that is slightly different how it's gonna come out. All right, so we get to the day of surgery. We went over different type of plannings, different options. And we're getting ready for surgery. I have to warn that there's some bloody pictures in here. This is what I do every day. I'm in the middle of all this. So if if this bothers you, I mean, it is what it is. There's a lot of blood and open gums, and this is basically what happens at the day of the surgery. So the day of the surgery, we have this case. This was a young patient. He had some history. He was a candidate for an L14. We have the dentures and the stents ready. This is the case that I showed with the stents prior, a couple of slides before. And we're getting ready for surgery. So this is what happens the day of the surgery. The doctor or surgeon or orthodontic, wherever I'm working with, we flap the tissue. So we open the gums. The doctor removes the teeth, and then we start placing the implants. And of course, keep in mind that they have their planning. They know where they're placing. They're just doing it freehand. So we place the implants, they torque it down, and sometimes they'll use my guide to see how the implants are coming out. We use multi-unit abutments for every single case. So we want sternal connection. We never do a straight to fixture. And in this case, sometimes they'll ask me, do you like how it looks? How the implants are placed. I'm like, there's just so much I can say about the placement because that depends on the bone and depends on their planning. But using the guide already helps me visualize what kind of abutments we will need for the future. So looking at those two anteriors, I already know, okay, maybe we get away with 2 straight, or maybe we do 17. Definitely we don't need a 30. So we are already able to go through the inventory and know what kind of implants we will need, what kind of abutments we will need to use once the implants are placed. So once they're placed, we keep using the guide. Those are the multi-unit abutments. We try to keep them all inside that lingual opening that we design. And we want to, we don't want the implants to come through the facial of the teeth. And, that second picture, well, not here, but you'll see that they kind of seem a little bit divergent. They're not, I guess it's the angle of the picture. So the abutments are placed. We close with suture. We put healing caps to protect the abutments, and then the surgeon sutures the tissue. And at this point, we are ready for the conversion. So this is pretty much what happens every time I go for the surgery. That we flap the tissue, we level the bone if we have to. We place the implants. Place the abutments, and we're ready for the pickup. So the pickup, we have the healing caps, and if you go on YouTube or anywhere else, you see the process is well explained, different videos, different presentations. But there's you have to be aware that when you see those kind of presentations, that you have the perfect model with the perfect denture, they all fit perfectly into that model. For this type of case, it's not so easy as it looks in the pictures, because there's always some kind of deviation. It might be rocking somewhere. The muscles might be pushing one way, from one way to the other. So you have to be really diligent in how you're doing things and look at all the little things or details that might happen at the time of the conversion. But the process of the conversion is pretty much pretty straightforward. So we use blue mousse or any type of PDS or impression material. We inject that material into the intagli of the denture, and we try to seat the denture on top of the healing caps. That will tells us where our implants are and where we need to drill the holes. We try to keep drill the holes as small as possible, because we don't want to go crazy and open big windows, because that will weaken the prosthesis later on once we covered everything. So we make some holes, we go back to the healing caps. We test again. I don't have that picture here, but we test the denture with the holes on the healing caps. You'll be able to tell the orientation if you need to trim a little bit more on one side or the other. So then we remove the healing caps, we place the cylinders, and we seat the denture through the cylinders to make sure they're all passive and there's no interferences. I have to say something that it bothers me um, a lot. That no matter what, I was searching on YouTube for videos about conversions, and they all show a big mistake that I feel that is like, uh, a big mistake in this type of cases. Um, we cannot cut the cylinders, or we should not cut the cylinders for this type of cases. When we're doing an all-on-4, if we're looking at 15 millimeters of restorative space, if you're cutting those, I mean, you need 15 millimeters for restorative space. And I know, or, I guess everybody should know that this is cylinder from Nobel. I know Straumann, they're slightly, probably 1 millimeter shorter, but a Nobel temporary cylinder or coping, it's 12 millimeters long. So if I need 15 millimeters of space and I'm using a 12 millimeters cylinder in length, um, I like tall, I know for a fact that that cylinder should fit inside my denture. Of course, sometimes there's some interferences. It's easier to just cut a little bit and avoid that. But if you see yourself cutting those cylinders 1, 2, 3, 4, 5, 6 millimeters, like I heard people saying before, you have a problem for the restorative space. And if you're the one person doing just the conversion and not getting the final restoration, you might think it's fine because you don't know what consequences that might have for the final. But if you get your finals, then you realize that restorative space is critical. And there's just so many things or options you can have if you have a short restorative space. So keep that in mind, that we should not cut the cylinders every time we try to do these cases. We should take the cylinders in consideration, or the size of them, because it's a guide that will help you to do this type of cases. Like once you do the conversion, if you see that your cylinder is picking out 2 or 3 treads, and for the cylinders, each tread is 1 millimeter. So if you see yourself cutting 3 or 4, you're changing from 12 to like 10, 8, or 7. So if that's the place, if that's the space that you're working with, then it shouldn't be like that. You should be aware of this. The size of the temporary cylinders will guide you for the conversion. So after we make sure that they're all passive, the holes, like you can see, they're not pretty wide, they're pretty good, there's no interferences. So we inject material around the cylinders. I like to use Like your resin. It's a lot, I feel that it's a lot better to use in the mouth instead of acrylic. Acrylic is runny, it's messy, it flows all over the place. I like the fact that the Like your resin, you have from the carriage, you use it in a syringe, and it's easily flowable. It's not dripping everywhere. You can you can go all around with the material that is not gonna drip to the patient's throat. And I prefer that instead of acrylic. It works a lot better for me. So inject around the cylinders, inject on the denture. And I like to when there's bone reduction, I like to seat my dentures to the mouth. I don't like to go through the occlusal. Then we cure the material, and once it's set, we remove we unscrew the denture, and it's ready is ready to finish. To finish, I can go back to the lab or my little corner that I have in the office and finish it up. And this is the final, temporary that is ready to insert. So this is double arch. So while I'm doing finishing up the denture, this time, it's not a denture anymore. It's a fixed temporary bridge. Once I'm finishing that up, the doctor is moving to the lower. Remember, this was an double arch, so he's using a guide for the bone reduction there to make sure that we have enough clearance. And I don't have many pictures because, like I said, I was working on the upper while they were doing the lower. But basically the same thing. Assess the bone, reduce, level it out. We place the abutments, and then for the lowers, I like to use the bite. Actually, I like to use the bite for even the uppers. But every time I use a lower, a rule is always pick up the cylinders with the bite, because I hate when my doctors spend. That never happened, but I know that their complaint is spending half an hour trying to fix the occlusion because the way that it was hold or the way that it was picked up was not good. So they need to level the occlusion and like spend half an hour trying to adjust everything. So I like to use the bite because this way, it's easily closed and like it's pretty much tiny adjustments if there's any overflow of material going on top of the occlusal for some reason. And this is the result of that upper and lower arch. So that was the pre-op. The patient in that picture is wearing a denture, a partial. He would not take full face pictures without that partial, but yeah, that is the best we could have. And that second picture was done the day after the surgery. He came back for a slight adjustment on the bite.
Dora, I have a
Yes.
question. I have a question. What do you use to drill the holes? If they're asking if you tie the cylinders together with a wire or fiber before injecting the acrylic.
No, I don't do any fiber or any kind to connect to splint the cylinders. If I splint them.
Yes, obviously, if you are picking up with the denture, you are splinted with the denture. But I don't know.
I don't use any. I don't use any reinforcement on the cylinders. No. At the time of that pickup, I don't. It's the denture is splinting the abutments. There's no. It's the resin, baby. No. This.
Yeah, that would be. Usually in the secondary impression for the final, maybe.
For the final. Yes, for the finals, definitely. For this stage, because the mouth is the best, is the most passive way of picking up or splinting those implants. So we're doing that with a denture. So there's no. If I had to add some sort of wire or anything around the cylinders, then I had to worry with fitting the denture on the wire and the cylinder. So that would be more trimming inside of the denture to make sure it would sit it. And that would take, even like securing the denture, with a wire. I did a case that the doctor wanted a temporary, long-term temporary conversion. So he did a mesh in metal for the time of the conversion. But the problem is that it was not easy to stabilize it at the time of the conversion. So the mesh kind of moved out of the place. It kind of created a flange on the lingual that was not the best for hygiene. So no, I don't see the need to reinforce with anything inside, because like I said, if we have enough restorative space, we shouldn't have any problems with breakages or the need to reinforcing.
Referring to that, I have a comment from Dr. Jeffrey who's how you if you have a trick to he comments, I'm fine verifying occlusion at this point. A problem because of cylinders and I cannot bite down. If you got a trick to, I guess, to assess restorative space at the bite registration or the mounting or um, process.
I didn't understand the
When
question.
you're planning the case, when you, I guess he's referring when you're planning the case.
Mm-hmm.
If you have a trick to know the restorative space that you will need for the conversion process.
Yes, I'm always looking for the 15 millimeters of restorative space. So I don't follow, when I'm planning either analog or digital, we're using the tools to make sure that we have enough clearance. So if we're positioning the tooth and, we're measuring from, the incisal of the tooth up to the part of the gingiva, those 15 millimeters, and then we'll guide our planning through that. And that's at that point that we need to realize, okay, I need to cut, I don't know, maybe I need to cut like 3 millimeters of bone. And the surgeon says, no, you can't do that. Okay, so let's see if we can play with the vertical dimension. Maybe the vertical is slightly close, we can open 1 or 2. So those are part of the planning. So you need to take that measurement in consideration, and you have to try to have, that measurement in your head when you're planning the denture. So when you go for surgery, you have the guide that will record that, that measurement that you created before, and the surgeon can follow that.
My next question regarding that is, if you're doing both, um, how you manage that situation when you're doing a full case? Do you use any kind of bite registration guide, or that's what
For the pickup?
yeah, how you handle that situation when you have a double arch that you're going to do a conversion? And because also someone asked, um, do you pour resin at the time? How you control no balancing or moving? That's a
The
different
pickup,
question.
we're talking about the pickup.
Yeah, one question is when you pour and cure resin,
Mm-hmm.
at the time, how you control no balancing or moving? I guess like going off the.
I use the bite. I add the material. We inject material around the cylinders. We add inside the denture. We seat the denture. And when you do the blue mousse to tell you how much where you need to cut the holes, that blue mousse will have a thickness, and with that thickness you can already tell how much material you should inject on your denture. And the reason that I like the light cure resin is that because it's not messy, you can inject it and it stays pretty much there. But if you stay there, start dripping. So you inject on the denture, you inject around the cylinders, you seat it, and then you bite down. The bite is holding in place, and then you cure it.
And how you handle a situation where you have a double arch? Do you use like a putty bite to make
For the
sure the
bite.
bite, or you do
So
one at a time?
no, we do one at a time. We always do the upper first, and then we move to the lower. For that bite, sometimes I'll use, or before I, well, sometimes I'll use a silicone putty, or what Avident has now is called occlusal blocks, that you can request that those occlusal blocks is basically a little bit of acrylic that you can, it come built on like the dentures, and once you go to the mouth, they occlude properly. They have the little block there that occludes the dentures in place correctly. So you can use either one or the other.
Okay.
And if you do the planning, you know how the teeth should align. So like I said, I like to use the bite for the pickup. So once you see that is lining up before the pickup, then you just need to inject the material, seat it, and close. You see that the bite is lining up, and then you go from there. But definitely those occlusal blocks, from that Avident does at least,
Are
are
helpful,
good
yeah.
for that. Yeah, they're helpful.
Okay. And just one question before you continue, the last one. When you're printing, what resin and what printer you're using?
So I have an Asiga Max, so I'm limited to the ones that I can print with it, but I use Dima, Dentka, and Nextdent. So I start using Dima initially just because, or Dentka, just because it was, through Vita Shade. So it's an A1. I'm going to have an A1. I had a hard time like matching the colors with the Nextdent, but I felt that that was a little bit more brittle. I felt that the end of the Nextdent was a lot stronger. So now I use Nextdent for all my printed cases.
Okay, thank you.
Okay. All right. So we got another case. So this is an upper only, and in this case, it was a patient that only had a couple of teeth, and we were able to do a try-in and access the restorative space. We had ability to confirm that before before the surgery. So I use a slightly different way to pick up the cylinders in this case. So the same thing happens in the surgery. We pull the teeth, we flap the tissue, pull the teeth out, flatten the bone. In this case, we didn't have much because we had enough clearance. Well, we still did a little bit, I think, but we didn't have to do much. The surgeon places the implants and the angulator abutments. I don't think I have the picture with the guide, but it's pretty much the same. Place the abutments, healing caps, we close the tissue, and then we use the denture to the same way to pick up, to mark the with the blue mousse where the implants are coming out. In this case, because like I said, we did a trying, we confirmed the bite. We know that the position is perfect, like the denture is perfectly positioned with the upper. Because when we're working with like cases that we need some kind of bone reduction, once we flap, sometimes we lose a little bit of control of that. In this case, we didn't have that, so we were able, if you see that hole there, we will be able to tell, we'll be able to see that the denture was sitting in the palate properly. You can see the blanching of the tissue. So it's just another way to confirm the position. So we remove the healing caps, we place the cylinders. I like to use Teflon tape instead of any sometimes it's whatever the office has or wants to use, but I normally have the Teflon tape with me. I prefer to do that because there's no bacteria sticking to it. Not that we have that problem here, but it's a lot easier to use. You do a long piece of Teflon tape and you put it in there. You're sure that once you have to clear the cylinders, you pull from one extremity and everything comes out. There's no sometimes the bite registration kind of breaks or you have a hard time trying to pull it out of there. So we put the cylinders, we have the Teflon tape, and then we make sure that the denture fits and is passive. There's no interferences and with the cylinders. And like I said, this way is slightly different. I tested the bite first, but I injected from the bottom, so I was able to see with that hole over there. I was sure that it was positioning right, so I injected from the bottom. And in this case, I use this is a Q resin from I believe Bredent, and this is like self-cure acrylic, I must say. I use different ones. It really depends on the case. So I like to use a resin, like your resin. I like to use, it's not that I use a couple and they both work. It just depends on the case and how you're more comfortable to work with. And then we remove the denture and it's ready to finish. Yes, you have something? Sander, you have something?
No, you can continue.
Oh, okay. All right. So yeah, basically we are, once we remove it, I finish it up, polish, it goes back to the mouth and is inserted and is good to go. So
I have a question. Hold on.
yes.
T-Bag is asking how often you have fracture of printed dentures versus acrylic dentures.
So
I guess he's referring to a
printed.
printed denture versus an an analog normal denture process.
I've done, I can say probably I've done more than 50, let's say 10. I don't know. I can, let's say I did more than 10, or let's say 10. I don't know, 10 or 15. I don't know. I can't recall. But I had two printed cases that it broke. And the reason that they broke is because there was not restorative space. Um, and it was done with Dima. I don't know if it's related there or not, but I use Dima resin. I used Nextent. Nextent never broke. The Dima did, but I have to say that the problem was not the material; it was the restorative space. And actually, I have one of those cases to show at the very end why that was wrong, or why that broke. But I don't have problems with, you know, they can break, but I have probably like maybe two out of, like, for the last 3.5 years that I've been working on my own. I have probably two, three that maybe broke. And when they break, you have to see what the problem is. Sometimes, I have a case that we stop at the second bicusp, and the doctor wants to keep uh, to the second molar, and there's a cantilever there, and I know that for a fact that that's going to break, but the doctor still wants to keep it. So, okay, it broke. Was it for the material? No, it was because of the cantilever. We already know that we cannot leave that cantilever, after that last implant. So another case was we had a full arch, and this was milled. It also broke, but it was not the resin. The patient had teeth from 3 to 9 on one side, and we were doing the lower, and the implants were placed on the other side. And because the last implant was the canine on the lower, the you know the patient wanted to keep all the other posterior teeth, so we had a cantilever of 4 teeth. And I told him, this is going to break, you can't do this, like, you have to, why was the surgery done this way or not? But I can't just discuss to a point, but this is what I want. I know it's going to be a struggle, but this is what you need to give me. Like, okay. And I did that, and of course a week later, or 2 days later, it broke. And you have to look at the entire thing. It's not just the materials, is how the restorative is done, how the implants are placed, how ungulated they are, if they're divergent or parallel, if the treatment plan was done correctly. There's a lot of things to consider. So I don't have a history of breakages. I do have some, but I do believe that it's not just about the material. It's about in general, a mix of the material and maybe the protocol or something else that failed there.
Okay. And do you ever, if someone is asking if you or the doctor use rubber dam for the process of the pickup?
Yes, sometimes they do, sometimes they don't. And I don't like to use rubber dam, honestly, because sometimes it gets stuck in the material. But it really depends. It really depends the type of suturing that the doctor is doing too. I have one of my surgeons that he sutures. He does the flap through the lingual, not the lingual, the buccal. So he will flap the tissue from the anterior region. So he flaps it, and then when he sutures back, all the sutures are on the facial side. So the ridge, the top of the ridge, is completely clean. There's no blood, there's no sutures. It's like a lot easier to do, a pickup like that. And in those cases, we don't use rubber dam. So it really depends on how the sutures are, and the type of material that we're using. If I'm using acrylic, doesn't matter if it's a in a syringe or in a cartridge, like I'll use rubber dam. It really depends on a few different things.
All right. Thank you. I will ask another ones after your presentation.
You have more?
Yeah, a few more, but
Oh, okay.
continue, and we will close out
Okay,
with those.
how far are we? What time is it? Oh, okay. Ooh, okay. So we're almost done. This is the last case, and this is actually part of the master's specialty program that we were going to do actually at the end of April here in New York. And then we had another one course scheduled for Canada in May, but unfortunately, due to this coronavirus, we had to postpone it. But this patient is part of that course, and that course goes into detail, how to do proper planning for this type of cases, like different situations, like a lot of gingival display, a lot of reduced vertical dimension, how to properly do a planning for all on fours, basically, how to analyze the face, relate to the bone reduction, vertical dimension, and so on. That course also has, new protocols, new conversion systems that I've been using since last December or November. And they're amazing. They can speed up this process of the conversion. So it's slightly different than this one. Digital approach, analog approach, hands-on, so very full integrated. But, I add this patient here because the slides that I have for the process of the conversion are pretty, they're good to kind of use in this scenario as well. So this patient, the bone was really inflamed. A lot of gingival display. The plan was canted. It was a tough case, and one thing that I have to say that sometimes it bothers me, like there's just so much I can share like on social media about these cases because this is what I do. I do these things all the time, but there's always those people that don't look at how of the type of work that you do, but more like, why do you do this? Why? I want to see the x-rays. Why is this patient like, why are you destroying like this bone? Like, and it's funny that I had a conversation a couple of times with Dr. Steve Park, is well known in the Instagram community with the implant guru, and even him like posting cases, and like there's a lot of people like on top of you. I want to see the x-rays. I want to see, why did you do this? Why do you do that? We have to keep in mind that the patients there are candidates for this type of procedures, or if we have one of these cases, it's because they took that decision, or the plan was presented to them. The doctor, the surgeon, or whoever was part of the treatment plan with the patient, they took that decision. So we shouldn't be so quick to just go and, I want to see why you did this planning. Maybe all on four was not for this case. So anyway, just me ranting a little bit. But we have this patient, and like I said, if you see the gingival display is a lot, and in this situation, like I said, this is my surgeon that he flaps from the lingual. This case, we needed a lot of bone reduction, but that's normally what he does. He will flap from the lingual. We remove the teeth. In this case, he was just kind of like pull it all together at once. He just saw basically across the arch, level the plane, place the implants, and this is an all on four. And this is a Straumann case, so we used the guide in order to make sure that the implants, the abutments were in the right position and parallel to each other. That picture doesn't really justify, kind of seems that they're all over the place, but I guess it's the angle because they were not that bad. So this is a Straumann case, and what I like about Straumann and how I can tell, like the healing caps are slightly different from Nobel, and these are the two companies that I work with the most. I like the fact I love them and I hate them. Sometimes it's like a struggle to try to fit a denture because they're too tall. But in this scenario, because we had a lot of bone reduction, it's nice that we have that cylindrical form that once you do the impression and you see it on the mouth, it will be, it will give you a clear path where you should, where you're going to use your burr, the direction to open your holes. So the same thing, we use the impression material, we sit it in the mouth, and as you can tell, it's really well defined where at least the direction or the angulation that you should drill through the denture. So we roll the denture, we sit it back, we make sure that it's not interfering with anything. We're still with the healing caps because they're tall, so you'll be able to tell it right away before placing the cylinders. And then we replace the healing caps for the cylinders. We place the Teflon tape. Cylinders are in. Again, the cylinders are not. We're not cutting the cylinders. We try to keep them, intact for the pickup. We inject the material in the denture, you seat it, and like I said about, to answer the question, there's a lot of bone reduction, so once you occlude, you can keep the occlusion down and cure the material through the through the through the flanges. Keep in mind that this particular material is dual line from Dentsply, and I had a couple of discussions once or twice about the material doesn't work because it breaks or it's not working. I know that I had this discussion before, and again, we have to keep in mind that sometimes it's not just the material, just like the question about printed dentures, do they break or not? It depends on other factors. You can't just look at the type of the material. If you have the same scenario for every single case and then one break, then you can tell there's material. But if you have different scenarios, you really have to you have to take into consideration every single thing that happens in each one of them. So for these cases, you have to use a strong light if you wanted to cure this material properly. I use the Valo cordless, and pretty expensive for me to have, but I use it every day, and this is the only light I know that it will cure the material through the acrylic. So the wavelength is so strong that will go through will pass through the acrylic and cure the material inside. So there's a lot of lights out there. If you happen to use this and try some light that your office or the doctor might have, you might not be curing the material enough, and you might see a problem down the road that is not picking up or is breaking because you might blame the material, but honestly it might be the light or the way they're picking up, or that you're curing the material, because some lights are just good for direct curing. This one I know for a fact that is good for indirect. It will go, it will cure through the acrylic. All right, so we cured it. We pulled the Teflon tape. So, as you can see, I like those big pieces. You fit all, one long piece in there. It's easily to remove. I had a situation once that the doctor preferred to use, he brought his Teflon tape and it was like tiny pieces. And, I kind of tried to convince him that I could do the Teflon tape for him. He didn't have to use his, but he insisted that he knew how to use those tiny pieces. And then what happened was that he spent at least 20 minutes trying to pull, the last Teflon tape that it was right there at the bottom of the cylinder, and he couldn't, take it out because there was material and blood and everything. So use a long piece, and he got to a point that even blame, maybe the material, it got stuck into the sutures. No, the problem is that the Teflon tape was really tiny, so we couldn't pull it out. So if you do that, make sure you do one big piece, even if a little extra pieces are sticking out. Just leave it like that. It's easier to find it and remove it after the pickup. So that's it. We remove the denture, we trim it out, polish, and then we insert it back in, torque the cylinders, and this is the final result. So I have a little video. This was at the day of the surgery, And this is, of course, she's still, all swollen and um, you know, but it was a pretty good outcome. I loved how happy she was and how good it looked at the time, honestly. Do we have any more questions? I think not. It's pretty self-explanatory, right? All right. So last part, and very briefly, I know we're passing our hour already. This is just consequences of bad planning and why is this important. So um, you can be great doing a conversion, but if you don't understand how the planning works or how you need to set initially your teeth um, for the the right position, the right restorative space, or if at the time of the conversion you see something wrong, like you don't have enough restorative space, or what kind of solutions do you have if you see that something is off right there. What can you do to avoid bad outcomes? And I have three examples of what bad planning can um, do, let's say, or how it can happen, and why I don't like it. Um, so this is a case that I got from a doctor here. He sent me the model. He sent me the final bridges as per the patient, and she was not happy how it looked. She wanted to get some, he wanted to get a new bridge, and he was looking to see what we could do. So just me analyzing the case, I just saw, there's a big, you can't really tell. I was not expecting to have these pictures. This was honestly pictures to send to the doctor to discuss something, was not to keep. I was expecting actually to actually do this case. But you can see the model, the implants are all divergent. There's a big chunk of a bone there that was not leveled for this type of surgery. The implants, the inclination, everything is coming through the facial. You can't really see, but there's like flanges all around. There's a bar in there, but I don't even, probably like 2 millimeters thicker, if that much. And when I was assessing the case, okay, something was wrong here. Let's try to figure out what we can do. I was like, what can you do? The patient needs something else. And just looking at it, okay, maybe we can use angulated abutments, bring the holes inside. Maybe we can open the vertical dimension a little bit because we need space. The flanges are like ridiculous. And still we need vertical. We needed to somehow work with the vertical, because once we put the angulated abutments there, you will see the metal for that. So let's see what we can do. So, okay, the patient was Portuguese, and the doctor said to me, you have to explain that to her because I don't know how to. So I went to the office and I explained, the patient, like whatever I could do to help, but it was not going to be a great outcome because I was just limited to what I could do and the conditions of the model. But I had to see the patient, I had to see this in the mouth to see how I could move forward. And after she put that in the mouth, this was, what I got. So after, half an hour talking to her and trying to tell her how I could make her bridge better, I had to apologize and say, I'm sorry, there's nothing I can do here. You'll have to go through you'll have to go back to a denture, or you'll have to just, pull those implants out that were old. We didn't even know it was an old, were not the ones that we were used to have. And, you have to pull those implants out and place new implants, do a level, bone reduction, and plan the case properly in order to have something. So this is, this is bad. And this is obviously a bad planning, no matter how good you are with doing the conversion, because you can do it. And, don't think it's just putting some holes through a denture and pick up some cylinders, because it's a lot more than that. But, the planning was bad. So no matter how good the conversion was, you couldn't give something good to the patient. The second one is when the patient wants to use, the old denture to save money, or even, if the denture is planned somewhere else and is it's designed as a denture. um, you know I try not to use old dentures anymore because I got this case. And when you're doing the surgery, when replacing the implants and more the abutments, you're limited to the information that you are bringing to the office. So if you have an old denture that is not properly planned for an all-on-4, you're following the denture to guide yourself with the bone reduction and the position of the abutments and all that. So you get um, this type of cases, you get a shelf in there in the interior that you should not have, because you're going to have like a bulky lip in there that should not be like that. And then you see like number 10, that implant is almost the facial. So it's not like, even for moving to the final, we can push those teeth much, you know, more, into the occlusion, into class 1, because that is right there. There's just, we're limited to what we can do there. So again, it's not so much about bad planning. It's about using an old plan and not adapting it to an all-on-4. That, like I said, dentures, setting teeth for dentures are completely different than setting teeth for an all-on-4. And my very last one, and to answer that topic about printed dentures that break, this is one of the cases that broke. And as you can see, I must say that this is unacceptable to deliver something like this, even as a temporary. And, the planning was done right and the conversion was done right, but that was according to the abutment position that the surgeon placed. So as you can see, there's not enough restorative space on those 11, 12, and 13. And they're all divergent. They should be parallel as possible for a good pickup, and also for the insertion. So the surgeon didn't use the stent that was provided. In fact, with this office, the surgeon does his part, he leaves, and then it's up to the restorative doctor and me to do the conversion. So even at this point, I try to ask the doctor to, rotate, change the abutment on that number 7, because it's ridiculous, like having something like this. And, maybe she didn't want to change it, or she didn't have inventory. I don't know. It's just like, it's a temporary, and this works fine for the healing stage. Unfortunately, I don't think like that. We should not think like that at all. Patients pay a lot of money for these type of cases, and I don't think this is acceptable. But it is what it is. And this is how I end my presentation: that you have to have a good relationship and communication with your doctors, because clearly what happened here was not having the communication, not being able to communicate with my surgeon at the time, to follow my guides properly, to make sure that everything is parallel, or even to give my opinion. And I think that the best about these cases is the teamwork that you have behind you. It's not just you. These are some of my doctors, surgeons, prosthodontics. They're all amazing. And we have to realize that for this type of cases, we have to work as a team, because at the end, we're just trying to give the patient an great experience. And that can only be possible if we all communicate and trust each other. And it's not just a matter of pointing fingers if something goes wrong, because sometimes things go wrong, but you need to be able to discuss and being able to accept criticism. And at the end, we're just trying to add more value to the treatment, and ultimately to the patient's experience. So being able to, if I have to, I don't have to go through the front desk to call my surgeon, or if I have a question about some case and it's like Friday night and I just remember, I can text my doctor directly. That is the type of relationship that I have and I'm blessed with. And I think that anybody that is working on this type of cases should have, because it's all about team effort and teamwork, and only like that you can deliver a good product, because it's all about communication at the end. And that's how I end. So tell me, do you have any
Thank
more?
you. Thank you, Dora. Excellent presentation. Thank you for the information. Yes, I have some questions, and we can finalize with some comments and questions from everybody. Um, the first one is, what kind of resin composite are you using for in case you need to characterize any of these monolithic printed prostheses, and if you are doing so, or and what is, I guess, what is that you're using?
I'm using I have Ivaplar Nesco, and I have wait Annexent. So I have those two. So I'll just use one or the other.
Okay. And how long it usually takes to print these prostheses? If you have to, you're gonna use a printed denture for the conversion.
Uh, I don't know, maybe like 40 minutes, maybe an
Okay.
hour the most. Yeah, it's not much.
Now, do you feel comfortable using these printed dentures for final restorations? If you do so, or
For
you do the finals with a different type of process for um, um, on your prosthesis.
yeah, no, I don't feel confident using printed. No, I know that. I mean, I'm looking into try different things. Like I said, I'm just limited to what I have and how I've been working so far. I'm looking to maybe, um, get more into the digital, get more into the digital technology. Maybe get an intraoral scan, and then I'll be able to scan the patients, at the day of the surgery or before or after. Maybe get the pic camera, and then I can, go to the office, and instead of doing the conversion in the office, maybe get the records and send it to a designer that can quickly do the design. And I just, if the doctor has a printer in the office, they can print and deliver a full print, a full printed bridge. Or, I send it back to the lab and then deliver. There's different protocols out there. There's some doctors that they only want to deliver the next day. And, when that happens, I actually had a lab that I was working with, that I'm supposed to teach them like about the workflow, the conversions and so on. But they were saying that their doctors, they only deliver for the next day. So it's still viable. You just need to figure out how you can make that happen. Like I said, this is the basics of the conversions. That's what I've been doing my entire life. But I'm looking different ways to change, because, with the technology that is here, we can do a lot more things now, and a lot better, maybe. I'm not saying that what I'm doing is wrong, and that it works. It's been working for years. But if there's something that is going to make my life easier being a one-person lab, I'm going to look into it to see if I can offer that the type of experience and workflow for my doctors.
Okay. Also, what the light curing unit that you're using for curing the resin on the pickup? What
It's
from
the
what company?
Valo as um, it's the Valo cordless. It's some company out in California, Florida. I forgot.
Yeah, we can
I can, yeah, I can
post
post it.
later.
It's the Valo, Valo cordless. It's I just I don't know. I can say I'm gonna shoot
Great.
something.
We will post it later.
Yeah.
And how do you use, if someone was told that using a printed denture you cannot add acrylic for the pickup, so the cylinders. So are any of the materials that are you using?
Resin. So
Yeah.
the dual line works perfect. That the printed resin. So when either I have acrylic, I use a lot of materials for pickup. So I use dual line, that is light cure. I use Stellar from Top. They're here actually in Jersey. I use Vocal. I use like the Quick Up. I use Q resin from Breathend. I used what else? I use I think that's it. Maybe more. Um, but they if you're using like your resin with printed resins, it works fine. It bonds like amazingly well. You don't need a bonding or anything. If you're using acrylic dentures or analog or milled, if you're using PMMA, there's a bonding that comes with the kit that you just need to use the bonding and the resin, the like your resin bonds to the acrylic. So but in terms of printed resins, I will use resin, like your resin, because it's the same thing. I wouldn't use acrylic for a pickup. I don't even
Okay.
use acrylic for a pickup of on the.
How do you rank the temporary prosthesis in terms of a strength? Acrylic dentures, milling, dentures, printed dentures, uh, PMMA, mill dentures. Do you?
Um, I I can't really say that milled 100%, but I can't say that milled are 100% better than the analog, like the ones press pack in the lab, because I've done those for years and they always worked. Like I don't see, I see problems with the printed denture, but again, that is converted. But again, I cannot say it's just the material. Something else happened between the milled and the analog. I prefer the mill 100%. I'm more confident with that. But I can't say that I had many problems with the analog dentures. So, like I said, they both work. It's just a matter of what fits your business. For me, it's a lot better to use mill because I prefer to concentrate my time. My focus is in the planning, and I can't do that if I do it digitally. Because if I had to hire someone because I'm so busy with work, I still had to be there controlling the planning. Because if you do it in the model, once you pull those teeth out, you lose your data. So you don't have to, might as well I have to do the planning myself or trust someone to a point that that can do it. But again, I'm a control freak, so I prefer to just outsource that and outsource the milling, so I can concentrate in being there for the surgeries that sometimes I get 8, 10, 12 a month. It's not always, but sometimes if I get 10, 12, I still have to do the finals after. I'm not just doing the planning and the conversion. I still get all the finals back after the healing stage and the process and the conversion, once the implants are integrated. So I'm it's just me. So I'm kind of conditioned. So I'm trying to send everything I can out to a point, that I happy with the product. But I prefer mill now, but I can't say that mill is better because the analogs break. I can't say that because I've done analogs for many years and I never had a problem.
So I'm going to, with these two final comments, Leticia Otero Duran is asking, I would like to get more information about the Master Specialty Program, if this is going to be available online or later in New York. Will I have a class like that in Washington, D.C. sometimes in the future by any chance?
I guess it's just a matter of playing it. I mean, now we're kind of like on hold to see when can we go back to work.
Yeah, I guess we will have to wait
And it's
until.
just a matter of see, if we have enough people, I guess, in Washington, or try to schedule something. But at least we have those two. We have one here in New
Toronto
York,
and
or in the States, and one in Canada. So I guess we can do more. It's just a matter of,
getting back
making
to
sure
normal
we
after
have
all this situation. Yes,
yeah.
and we will thinking a way to bring this program online at DDC website, and so just subscribe and so you get notified with any events coming up. And also, so I want to finalize saying every someone, we really appreciate that you guys are doing this is a comment in these crazy days. Happy Easter to all. So yes, happy Easter to everybody. And I just want to end that presentation saying thank you, Dora, for all your time, your knowledge, sharing
You're welcome. Thank you for
everything
having me.
about
It was
this
good.
this great topic. And hope to see you again in any other events here at DDC. Thank you.
Yep. All right. Thank you.
Thank you, guys. Thank you for watching, and have a good weekend, everyone. We see you tomorrow. We will have more events. We have 2 more events tomorrow, Friday, and then we will continue on Monday. So look out for those informations in the DDC page and DDC website. Thank you.